From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
This is Dr. Preeti Malani, JAMA Deputy Editor and Professor of Medicine at the University of Michigan. I'm joined by longtime colleague from the world of infectious diseases, Dr. Jeanne Marrazzo, who is now the Director of the National Institute of Allergy and Infectious Diseases at the National Institutes of Health. She's the lead author on an article titled HIV Pre-Exposure Prophylaxis with Emtricitabine and Tenofovir, Disoproxil, Fumarate among cisgender women, published online March 1st, 2024. Jeanne, congratulations on your new role, and thank you so much for making time to join this conversation today.
It's great to be here, Preeti. Thanks for having me.
So one of the most important advances in preventing new HIV infections has been the use of oral pre-exposure prophylaxis, or PrEP. PrEP is an option for individuals at increased risk of acquiring HIV, and it's meant to be used alongside with other evidence-based prevention approaches. The drug we hear about the most is a combination of emtricitabine and tenofovir, or Truvada. And in fact, Truvada was approved by the FDA to prevent sexual acquisition of HIV infection in adults back in 2012, and that approval was extended to include adolescents in 2018. And the use of PrEP has increased substantially, but not uniformly. In particular, PrEP use lags among cisgender women. And one of the reasons is that the relative efficacy of Truvada for PrEP among women compared with men who have sex with men has been questioned. And this is due to negative results in some randomized clinical trials, including your prior work. And one of the issues that gets raised a lot is the notion of differential concentrations of tenofovir in vaginal versus rectal mucosa. Which brings us to the current study, which is a pooled analysis using data from 11 studies done in 6 countries, Botswana, India, Kenya, South Africa, Uganda, and the United States, and a final population that included more than 6,000 cisgender women. The overall goal was to evaluate PrEP adherence and HIV incidence. So with this lengthy introduction, can you please briefly tell us about the study, why it was done, and what you and your co-authors found?
What we wanted to do was to take advantage of data that were collected in demonstration projects. And these demonstration projects were part of the US FDA's requirement for the post-approval phase of TDF-FTC, or FTDF, we call it in this case, in cisgender women. These prospective studies occurred between 2012 and December of 2020, very, very minimal inclusion criteria. Basically, anyone who could benefit from PrEP, who was a cisgender woman, was able to join. There were 6,296 women aged 15 to 69 years old in 11 prospective studies. And those are the women that we followed. And on average, we followed them for 94 months to get a sense of what the HIV incidence was by varying levels of adherence over the course of observation. The bottom line of what we found was there were only 32 incident HIV infections, so really very uncommon. An overall incidence of 0.72 per 100 person years. And women who were younger, married, or nulliparous were more likely to get HIV infection over the course of follow-up. What we ended up finding, and we categorized women by several levels of adherence, and we overall ended up using 4: consistent daily use, consistently high use, high but declining use, or consistently low use. And the women who were estimated to use the product every day or daily, we observed absolutely no infections. In the consistently high group, we observed only 1. In the high but declining group, these are women who started out being quite adherent and then eventually tapered off. We observed 6 infections, and in the consistently low, 5. And so if you look at the incidence rate in the low group, the consistently low group, it was 1.27. So quite distinct association between increasing levels of estimated adherence with reduced HIV acquisition.
And before we talk about adherence, one thing I wanted to emphasize was the study population. And if you look at the full paper, there's a nice table that outlines some details. These were really vulnerable women, and they were at very high risk of HIV exposure.
Yes, absolutely. So when we say this is real world, it's not just in the context of the drug being available in the real world, quote unquote, after it's been approved or marketed. It really is so that you can make the product available to people who really need it.
So let's talk about adherence and how it was measured in the study. Can you explain the various measures used to determine adherence? And they were both objective and subjective methods.
So the subjective measures were what we had for the majority of women, 92%, and those included electronic pill cap monitoring. It's a good measure, but it's not as perfect as it might sound. We also used pill counts, so people would return their pill bottles if they were empty. The assumption is that they took the pills. Again, lots of potential pitfalls with that. We asked people to self-report how many they took, and then we also had them report on an adherence scale how adherent they thought they were. So lots of broad measures. The really firm objective measures include quantifying the amount of tenofovir diphosphate, either in dried blood spots, which are a very nice way to look at it. In fact, those actually reflect adherence over the past 8 to 12 weeks, or you can actually draw blood and look at the amount of tenofovir in plasma. The interesting thing about that is that reflects adherence over 2 to 7 days. And that's really not optimal because we have seen in many studies that right before visits, people might tend to start taking their pills because there's a chance that they might have some assessment of whether they were taking it. And we did not have biologic markers or objective measures in the vast majority of subjects. Once we got those data, we used different categories. So we looked at daily high, which we categorized as 4 to 6 doses a week. And that's going to be critical when we come back to the implications. Moderate, 2 to 3 doses a week, and then low, fewer than 2 doses a week.
Sure. And limitations around adherence data aside, one thing that's really striking about the results is that they're biologically plausible. Better adherence was associated with fewer new infections of HIV.
That's true. It's something that we know from pharmacokinetic modeling. It's something that we know from the PrEP trials where participants were randomized to placebo versus active product. I think what's really important with these data is, even though the concept is not novel, they are again showing you in a very imperfect real world setting that PrEP works when you take it, even for cisgender women.
Globally, most HIV infections, most new infections occur in women, particularly in young adults and even adolescents. In the United States, infections in women are also substantial. About 1 in 5 new HIV infections occur in women. But PrEP use among women lags, and this is globally. And it's something that we have talked about at length. How do the results of this study inform HIV prevention, both in the United States and globally?
First of all, there are, to my mind, a couple of reasons that PrEP use in cisgender women has not gotten to where we needed to go. First of all, our messages have been really confusing. We have been saying if you are a cisgender woman, oral PrEP won't work unless you take it every single day. And that sends the message that even if women are not having sex for a week or a month or 2 months, that, if you stop your PrEP, you're going to be at risk of getting HIV. So I think we have been confusing in the messaging. The second thing is that remember when you think about women at risk for getting HIV, really all you need to do is to have a partner who's infected. And that means you can have a single partner. And in fact, many of the women in our studies who have been infected with HIV have gotten it from monogamous partners, monogamous on their part, particularly in some of the African studies. So I think it's a combination of those things among others. And then of course, the third thing is access. You don't always have access to products. What this trial does, one, it adds to the perception that PrEP can work as tenofovir, oral tenofovir in women, if they take it consistently. And it strongly suggests that at least 4 doses a week is going to be adequate to protect against HIV infection. Again, we saw no infections in women in whom we estimated that was their frequency of use. The other big thing I would take from this, and we mentioned it in the paper, but one of probably the main messages is that when you look at the proportion of women in this study everybody who fell out as really not using the product very much. They started out high and they declined, or it was consistently low. That was the majority of women, which says that even if women do take this, can take this, want to take this, there are a lot of them who just don't want to use oral PrEP. And that's why we really need to talk about choice. We need to talk about the fact that long-acting cabotegravir is now approved for use in women, and that's fantastic. We need to talk about the fact that the dapivirine ring is now approved outside of the US, including in many sub-Saharan African countries. And we need to know that there are other options that are being studied that hopefully will give women more choice. And they will include combination contraception, PrEP injections, almost certainly. They'll probably include different long-acting products. These are all things that I think need to be part of the armamentarium for women to have access to.
Yeah, it's a remarkable time in HIV, and we have the tools to get to those elusive goals of 95, 95, 95, and beyond. Dr. Jeanne Marrazzo, thank you for joining us, and thank you for everything you do.
Thanks. Hope to see you soon.
To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This episode was produced by Shelley Steffens at the JAMA Network. Thanks for listening.